I'm going to be speaking today about something which I think is consuming a lot of thought at the moment, and it's workforce. And clearly this is incredibly topical given where we are at the moment with our workforces all over Europe and actually all over the world. Because this issue is, you may think it is a French problem. Well, if you go to Denmark, they'll say it's a Danish problem. If you go to the United States, they'll say it's a US problem. And if you go to the United Kingdom, they'll say it's a UK problem. But it seems to be everywhere, including in Asia, which is causing, of course, even more difficulty because in the past, a lot of the more developed and higher income countries used to import labor from the lower and lower middle income countries, specifically to make up for the shortfalls. But actually, they're short of labor themselves now. So this is a significant issue. And it isn't clearly going to get any better very quickly. So really, let's just think in terms of why we have the issues we have at the moment. And I think this is looking more to what the pressures are. And we're assuming that this is the end of the pandemic. I think we may be wrong in that. It is a pause, perhaps not this pandemic, but clearly there are going to be new pandemics. So the state of health and care has fundamentally changed. So we have an enormous amount of activity we have to catch up on, not only in terms of operations, and we all know the numbers of operations we have to do because we didn't do them during the COVID years. People awaiting orthopedic surgery, people awaiting care in a whole host of different places, elective surgery in general. But I think there's an even bigger problem, and that is the non-communicable diseases, because all the care for everything from type 2 diabetes, cardiovascular disease, etc., actually stopped during the COVID years. And it stopped during the COVID years because the health system was concentrating, quite rightly, on actually managing the care for people who were living with COVID. So that in itself, inevitably, means that these groups of people, and there are enormous numbers of people, I might add, are people who have not had the care they would have expected to have. Which means, of course, that we are likely to see later diagnosis, significantly later diagnosis in things like the cancers. And the effect of that, of course, is increased symptomatology, increased prevalence of these conditions because they're not treated early enough. And inevitably, we're going to see humps in the numbers of treatments that we're going to have to do, which would be over what we would have expected to do anyway. No surprise there. There's also new activity which the health systems are being involved with, which they didn't used to get involved with before. And of course, communicable diseases was something which actually took up very small amounts of time pre-COVID, but now is taking up a significant amount of time, not only in terms of health security, but also in terms of actually managing COVID and long COVID and all the other conditions associated with that. I don't need to talk to you about aging and societies because you're very, very clear that France, like a lot of European countries, is going through this increase in aging. You haven't hit the difficulties the Japanese have with a third of their population now over the age of 65. But, you know, we are aging, including the workforce, I might add. And with aging, of course, comes significant increases in multimorbidity, which I think we're seeing at the moment. And by multimorbidity, I mean people don't only have cognitive decline associated with dementia, they also have cardiovascular disease, they also have cardiometabolic disease like diabetes, they also could have things like strokes. So we have significant problems there. And the financial pressures, which of course are what drives health systems. Clearly, a lot of resources were spent on COVID, and as a result, inevitably, less resources will be spent somewhere else. And the fact that the professions have changed. Professions of medicine have changed, professions of nursing have changed, and they've changed insofar as there's a new way of working. Shift patterns are now something one expects. The fact that people work in shifts has fundamentally changed the nature of what they do. And the longitudinal care that existed, I don't think we'll be seeing that again. So just a final comment, and I'm not a fan, by the way, of the United Kingdom, but I bring this up because it is an extraordinary statement which was made. This guy is the present Secretary of State for Health. Of course, he was a merchant banker, like most Secretaries of State for Health in the United Kingdom tend to be. In other words, he knows absolutely nothing about healthcare. But that's not the point. The point really is he is allowed to make a statement like he made only a few days ago. The current model of primary care is not working and would initiate a program of change. Now, he's probably right, it isn't working, yes. And it does need changing, yes. But what is extraordinary is he made the statement, and the unions, the British Medical Association, the Royal Colleges, didn't respond. In the past, I mean a year ago, 10 years ago, a statement like that would have led to unbelievable reaction. How dare you, you're starving it of money, it could work, it should work. Silence. That in itself says an awful lot about certainly the profession of medicine, because both in hospital medicine and in community medicine in the United Kingdom, we're seeing a significant increase of numbers of people who are retiring early, not helped by the fiscal rules, which encourage that, and significant numbers of people who have left the profession. And we're looking at shortfalls of 20%, 30% of the numbers of physicians we need over the next 5 years, not over the next 20 years, over the next 5 years. And clearly the situation is untenable. So, you know, I've painted a pretty grim, I think, picture. But is it really inevitable that we're going to end up in this state? And I think there are things we can do and we should be doing, but let's just look at it from different perspectives first. And let's look at it from the perspectives of the workforce themselves, as well as the practice that they work within. So if we look at the workforce, I mean, morale is clearly not good. It never is good in the medical professions, to be frank, and the nursing professions, but it's worse than it's ever been. And of course, a lot of this is related to money, is related to pay and conditions, but there's other things which are going on here. We know about burnout, of course. We've seen the most extraordinary things happening globally in terms of people leaving the profession completely. And even in places like the Middle East, for example, somewhere like Dubai or Abu Dhabi, which rely on enormous numbers of foreign workers, often coming from places like Sudan or Egypt, and people who really work there to support their families. So these workers tend to work hard and, you know, to value their jobs. But what seems to be happening there is they had a crisis too, because after a long period of time working in COVID, they went back to their homes and didn't come back. They just don't want to do the work anymore. The same thing happened with all the nursing staff, mainly Filipino nurses, who went back to the Philippines and didn't come back. So this is something which is global. This burnout issue is something which is really, really causing even greater diminutions in workforce than previously. Again, there are things we can do about this, but we seem not to be willing to do them. We can help people manage burnout better, but we still, as employers, don't institute some changes that we need to make. And I'll come to what they could be. And finally, complexity. We keep on forgetting how complex practice is now. When I was first a physician, I had to remember about 20 guidelines, because that's all there were, about 15 or 20 at most. and the guidelines of treatment for conditions. And everybody was the same. People with hypertension of a blood pressure more than something over something needed this first, this second, this third. Now, of course, care is personalized, precise. Precision medicine is the way we practice. And if you count the number of guidelines, they're not 15 or 20, they're 15 or 20,000. Because, of course, each one has to be personalized, associated with the level of morbidities that patients have. So clinicians are put in a situation where they really have to make some judgments as to what best to treat, and they find it very stressful. And they find it stressful, A, because they want to clearly treat people in the best way possible, B, because they're limited to a large degree by the financial implications of what they decide, and 3, because they don't know the latest guidelines, because nobody can actually manage to keep up with all the evidence as it comes out. And we still don't have clinical decision support systems that work in the clinical flow to assist people with making these decisions. And then, of course, there's the media that still spends most of its time trying to make things, to heighten the litigious nature of medicine and of nursing homes, sometimes rightly, by the way. We had a big scandal in France, and we had, I don't know how many scandals in England. I can't remember. I think it must be in the hundreds now. You know, you've made a big fuss over your single scandal. It doesn't even hit the front page now when we have another scandal. There was recently a scandal about 3 weeks ago, and it was in the middle pages of the newspapers. I mean, you know, another one. It's like another crash on the road. So we look at what the pressures in what the practice environment for these health workers is. You know, perhaps now, because of the shift pattern, it is more conducive to work-life balance than it used to be. But we still impose an awful lot for people to do, which are mainly administrative. And often, of course, they're associated with us developing systems to try to assure the services we have to make them safe for patients, which is wholly appropriate, but we don't know how to assure very well. In England, we had something called the CQC, which was set up specifically to assist in actually rating, making sure that the treatment which is provided is the best that is available within the resources. But it ended up doing things like measuring the size of a room where treatment was being conducted, measuring the soundproofing, because actually it's really difficult to rate clinical practice. It's very easy to check on, is it being delivered from an environment which is conducive to care. So in essence, what they tended to do is drive a lot of administration and bureaucracy without actually measuring quality. And that, of course, is the biggest problem which every assurer has. And really, the clinicians were faced with doing more and more in less time. And in that time, not only collecting the metrics, which are part of the management of disease, but also trying to develop a relationship with somebody. And the relationship with somebody has changed dramatically, of course, because nowadays, people, quite rightly, actually do not necessarily accept treatment as something which, because it's said, has to be accepted. They question, wholly appropriately. They get engaged, wholly appropriately. And actually, the more engaged they get, the better it is, because that way they'll be more conducive to changing their behaviors. But clearly, consultations are much more difficult than they used to be for clinicians. That's fine, because that's the job. But all this increases the level of stress, complexity, and people really feel burnt out. Again, it is not unknown for people to go for a shift, 2 shifts, 3 shifts, spend a couple of weeks doing that, and then vanish for a short while they recover, and then come back a couple of months later. You know, the way work life balance has changed is really quite significant. But as I said, there are a few things we can do. And I think this is really what I mean to spend the next few minutes talking about, and then I'll stop and give some time for questions. There are things we can do now, and there are things which perhaps we can start thinking about that we need to do, because the system we have, as we know, is completely unsustainable. We have seen the effect on GDP of COVID. And now, to that, you need to add the effect of aging, the increasing demand on health and care services. So clearly, what we do at the moment and the way we do it, we can't continue doing this. To a degree, it is useful we can't, because now we have to change. And the fact there's no workforce has, in many respects, accelerated the changes which really should have happened 30 or 40 years ago, but didn't. But I think now they will. So let's think in terms of what we need to do now. Let's start with clinicians themselves. You know, how well did we train clinicians in telehealth? They didn't ask for telehealth. It just happened to them. They landed in it. And in many respects, they still do not know how to conduct a consultation using telehealth, because they use the same way they consult face-to-face and transpose it onto a video screen. Now, actually, there's an incredible amount that goes on in a face-to-face consultation. I can see you're engaged. You're looking at me. I can see you're twiddling your toes sometimes. You know, as a clinician, if I was consulting with you in a consulting room, I would spend most of my time actually not looking at what you say, but looking at what you don't say, but looking at how you are, whether you had a shave this morning, you know, no, I'm serious, whether your clothes are clean, whether there's a whole host of things that are really important in a consultation, and you miss all those on a video screen. But there are ways you can consult, and there is training you can give clinicians to really pick up and manage all those non-verbal communications using things like telehealth. But it isn't necessarily instinctive. Clinicians need to be taught this, and nurses need to be taught this. Video conferencing is very good for collecting metrics, checking on a rash, but it's not that good for actually figuring out if somebody's suicidal, figuring out how you're really feeling, and also figuring out what about the thing you don't really want to say, but in a face-to-face consultation, you'll manage to get the person to say it. It's these sorts of issues which training is available for, but we don't invoke it, which is very, very sad. We've spent quite a bit of time trying to devise these processes, and I worked with the dean of a medical school, specifically. He was a postgraduate dean in medicine in London, to actually devise the soft skills of teleconsultation for clinicians, not the hard skills. You need a computer, you need a good light. That's not important. Of course, it's necessary if you're doing the consultation, but actually that's not the skill of the consultation. Secondly, clinical decision support. I mentioned this a couple of times because we still don't have good clinical decision support systems. We have systems which exist whereby you press a button and you see a guideline. Now, you're doing a consultation in 10 minutes. Somebody's got multimorbidity. You need to look at 6 guidelines. How on earth you manage to do that, devise a program, examine a patient, do everything else within the time? It just doesn't work. And actually, it is possible to devise good clinical decision support systems which offer people choices in terms of what they need to do next. And they're within the clinical flow. We don't use them. Again, this would really help with burnout. This is the most significant thing which causes problems for clinicians because they feel very worried about not treating people the way they should be. And thirdly, AI. We're starting to now at least actually, incorporate it into workflows, and incorporate into workflows in a sympathetic way, not replacing clinicians, but actually making their job easier. For example, using systems to actually get radiography to a stage where the first X-rays which have to be assessed are the ones which are very abnormal. One can use all sorts of systems to assist the clinician. And at least we're starting to do some of that. But I think as important are the things we need to do now, it's the things we need to do soon. We've been talking about volume, not value, for many, many years. We've been, as a clinician, if you tell me that I get paid for everything I find wrong with you, I'll just look for things that are wrong with you. And if I don't find them, I'll just look a little bit harder, and I'll find them. And if I wait enough time and you grow older, bloody hell, I'll find a lot wrong with you. So where is this going to end? Because volume isn't really the answer. Value is the answer. And, the population health type approach is really where we need to go to. And there are countries now that are introducing systems iteratively, slowly, where percentages of care are related to preventative care. And there are countries that even went further and talk about prevention in all government. So, for example, the Department of Transport has to spend so much on prevention of accidents. Education has to spend so much on healthcare. How? Education around risky behaviors, cardiovascular health, smoking, etc., etc. These are the approaches, I think, which are going to help us. Secondly, ontology. By ontology, I mean the metrics we use, the things we collect about patients. The electronic medical record is really designed to assist the hospital clinician. That's how it was first set up. But we need a new type of record, and that new type of record is to assist the citizen, the people before they're sick, in terms of what's important to them in their lives. And there's work taking place even in Europe around developing these new electronic health records. And the regulations, the EMA is well known for being the slowest when it comes to license medical devices, especially software as a medical device. And clearly that is not something which should continue, because what it means is the citizens of Europe are not actually being able to access care which is possible in other places. And finally, data. And this is even more difficult. I mean, GDPR is wonderful. We all like it because it protects us. But actually, are the old definitions are they the right ones? Because people are now talking about foundational data rather than secondary use of data. This is a really big difference in the way we think. But one understands how difficult the discussion is going to be. But clearly, we're getting to a stage where we're going to have to rethink the use of data, because we can't continue as we are at the moment for very much longer without significant change. And finally, precision health, which really is the other side of precision medicine. Precision medicine we all understand, but we now know that non-communicable diseases are things which need to be treated for a lifetime. So we start managing care very, very much earlier. So really, we're fast approaching the fork in the road. Which way are we going to go? Are we still going to try to not recreate what we had before, because that's going to be impossible? But certainly, we need to decide whether we go faster or slower, and the decision is ours to take. So, over to you. We have a few minutes for a question or two. Thank you.
Inal, you mentioned there is a very important spot in training and education for the healthcare professionals. But I think you also underline that there is a need for global education of persons in terms of healthcare, in terms of knowledge. How do you think is it possible to properly implement it in the public health strategies? Is it something that you see coming in the near future in countries like the UK, in countries like France? Is there actually a real political will to shift the model for such strategies, to have more prevention and more education of the persons in healthcare? I loved what you mentioned, that most of the work has to be done with the education system. Education system is crumbling as well now. How do you see us getting out of this trap as well, and how to involve persons earlier in their well-being?
I think we will get there, even in countries like the European countries. Because actually we've run out of money. So in many respects, that's going to be the big drive to make change. But we are seeing some real examples of education taking place in terms of populations. And paradoxically, not in Europe, a lot in the Far East, and a lot even in the African countries. And a lot of it is related to the fact that a lot of totalitarian states, rather than democracies, find it easier to actually impose treatment, of course, and impose education. And they have introduced curricula associated with making people take more responsibility for their health. Of course, health is much more important for totalitarian states because it's part of the deal with the citizen. You know, I'm going to take your liberty away, but I'm going to give you good healthcare. In Europe, we spend a lot of time discussing things, but it will happen here, of course. And to a degree, it is happening. I mean, I led for England for dementia risk reduction. When I started, nobody believed there's anything you could do to stop cognitive decline. But now the papers actually come up with, and the media and the internet and social media are full of information as to what you can do. Some of it is complete rubbish. Some newspapers say, buy my newspaper and you won't get cognitive decline because you walk to these. I mean, but it doesn't matter because it makes people understand that there are things you do today have an effect upon tomorrow. So I think there is hope that we'll be able to do this. And I fully anticipate we will do it, yes. So thank you.
I have another question, the last one.
Yeah.
Sorry, but in all you mentioned, there is also technology that's underlying that as a support tool for clinicians, for persons. Right now, for what we discussed, we are far from being mature enough, and I guess the vendors have a role in that. What do you think they need to do next to go through this gap and provide solutions that are actually useful, create value for caregivers, and help them in achieving all what you mentioned?
Well, I think the choices are becoming clearer now. And really, one of the first things which people need to understand is the days of what I called walled gardens are over. A lot of vendors and solutions are based upon you have to use my system, and my system doesn't speak to anything else, what I call a garden with a wall around it. But we need to be thinking in terms, and they need to be thinking in terms of open architecture. They need to be thinking in terms of shared ontology. That is what is going to make the difference. And I think it will be driven, even the European Union now is moving in the direction of saying, listen, it has to, not only do they have to speak to each other, but they also need to be measuring approximately the same things for us to be able to use that data. So I think it's the interoperability, semantic and syntactic. That's the future. Thank you very much. I'm keeping you away from your coffee because I'm overrun by a minute. Thank you.